I've got 12:31, so we'll go ahead and reconvene the stakeholder forum. I know some folks are probably returning from lunch now and getting settled in for session 2 of 3 for our stakeholder forum, but we do want to be mindful of the time and keep on session because we've got just so much to share with you. So welcome back. Whether you attended the first part of the stakeholder forum today or not, welcome. This is session 2, and the title is going to be The Triple Focus of Healthcare. My name is David Takearts. I'm the Stakeholder Strategy Manager for CalPERS, and I'll be the moderator from this session. We're going to follow the same general format that worked with a few hiccups in the first session. I'll try not to close out the slideshow in the middle this time. So the basic format for you stakeholders, in case you're just joining us, is that you essentially are coming into what is in effect a darkened theater from your perspective. You're on mute by default, and we can't see your webcam. It would be pandemonium if we had the 100 or so people all active and speaking at the same time. So we have some protocols in place. If you would like to ask a question, that is available within the Zoom call. There's 2 easy ways to do this. The first one is to just hover your mouse over the bottom of your Zoom panel and click the raise hand button. That shows a little bleeping light to me and my team. And when we come to a break in the sessions, we will be able to unmute you and you'll be able to verbally ask your question or provide your comment or make your point at that point. So if you want to speak audibly to the whole group, go ahead and raise that virtual hand and we'll click on you and call you out and you'll be able to offer comment that way. The other easy option for you is to click on the Q&A button and you can type in your question there. The panelists will see that and we will be able to address that question verbally on your behalf. So if you type in the question, you're not going to be heard personally by the group, but I will go ahead and read that question on your behalf and attribute it to you when we come to breaks in the session. So those are the 2 easiest ways to do it. If you happen to be calling in on a phone while you're also watching your computer, maybe you don't have the best microphone set up in the world, so you've called in, go ahead and go to the chat button, please, as distinct from the Q&A button, the chat button, and just let us know which phone number is yours so that we can kind of rename the phone number you. Otherwise, we won't be able to tell if you want to provide comment or ask questions. We'll just kind of be in the dark there. And for those of you who are just calling in, you're not attached to a screen at all right now. If you want to provide questions or comments, you can email me, david.takearts@calpers.ca.gov, and I am checking my email throughout, so I will be able to ask those questions on your behalf. Lastly, this is a board meeting. We do have a quorum of board members participating, although there are no action items whatsoever on the agenda. Because of that, we do want to make sure that we offer formal public comment opportunities. So that will be available at the end of the session. We'll start first with the folks that are within the Zoom call itself. The folks that are participating directly in the forum will offer that. You'll have 3 minutes to provide public comment. After that, we'll go to the folks who are watching the board webcast, and we'll ask you to call into the number there, just like we've been doing ever since COVID hit. We've had the same kind of process in place to provide public comments by phone. So you call that number on the website and we will be able to patch you through and you will have 3 minutes to provide public comment that way. But just to be clear, that is distinct from the Q&A and engagement that we're hoping for throughout this session. Again, the idea is to be as informal and dynamic as we can be given the limitations of our virtual environment here, but that's our goal. So please don't be shy and ask questions and provide comment throughout and there'll be ample opportunity to do that. So enough with the housekeeping. Let's turn now to the matter at hand. I'd like to go ahead and begin the session. Our presenters today are shown on your screen right now. We have Don Molds, our Chief Health Director, Marta Green, our Chief for Health Plan Research and Administration, Dr. Julia Logan, our Chief Medical Officer, and Danny Brown, our Chief of Legislative Affairs. And the topic and session is going to be the triple focus of CalPERS Healthcare. Don, please go ahead.
Great. So good afternoon, happy Inauguration Day, and welcome to the new Zoom platform. I'm Don Molds. As David mentioned, I'm the Chief Health Director here at CalPERS. We have a lot of territory to cover this afternoon, so I'm just gonna jump right in. This slide outlines the game plan for this session. I'm gonna talk a little bit about the strategic priorities of the health program that we rolled out this summer, and then we here will be myself together with my exceptional colleagues, Ms. Green and Dr. Logan, are going to go into more detail about what we're doing now and in the future to meet those strategic objectives. After that, Downey Brown from our Office of Legislative Affairs will be joining us to talk about both the state and federal legislative landscape and about our priorities there. As David mentioned, he'll be fielding and sharing questions and comments. So if you have either, I encourage you to jump in by raising your virtual hand or sending a question directly to him. The session is intended to be interactive. So if you leave with a question or comment, burning a hole in your pocket, will have failed. So please ask or make them. If you could turn to slide 3, please. In July, the health branch released our new and improved strategic plan. The rest of the enterprise will be updating their strategic goals and objectives later this year, but we were so excited about ours that we left the gate a little bit early. So why the enthusiasm? As a team, we began embarking on a series of new initiatives in the fall of 2019, with the goal of moving forward on a handful of critical priorities of the board and more broadly with the goal of improving the health of our 1.5 million members. At the same time we were reporting out on the strategies and measures of the current plan, it became clear that the goals in the current plan were not completely aligned with new priorities. Specifically, we felt that it was important to evolve from a singular goal of healthcare affordability to a slightly broader focus. Our new strategic plan focuses on the triple aim of quality, access, and affordability, with all three working together to optimize performance and deliver meaningful outcomes. Another way to look at it, we can't just solely focus on affordability without negatively impacting quality and access. And we also can't just focus on improving quality without an impact to costs and access. To effectively improve the CalPERS health benefit requires the pursuit of all three aims in tandem. The triple aim was coined back in 2006 by the Institute for Healthcare Improvement. It's also the chassis upon which the Affordable Care Act was built, so aligns well with the structure of the health reform efforts of the last decade. The triple aim has three foci: quality, or ensuring that healthcare services are high quality and that care is patient-centered; access, so making sure that everyone who is served by a healthcare system is able to get the healthcare they need when they need it; and cost, aiming to reduce the per capita cost of healthcare. We believe that triple aim closely aligns with the CalPERS mission and how we plan to move the needle as we deliver health benefits for our members. Slide 4, please. The goal today is to really get into the meat of these three goals. But before we do that, I want to flag and then talk about the proverbial elephant in the room. COVID presents obstacles to all three of our strategic goals. A little bit later, Dr. Logan is going to give you an extensive update on COVID. As part of that, she's going to speak to the health disparities that COVID has both created and exposed. She's also going to speak to some of the challenges of delivering high quality care in a COVID environment. I'm going to focus my attention here on the challenges COVID has created for our affordability goal. COVID has introduced a high degree of uncertainty into our premium projections, and it is increasing and will continue to increase our costs. Some of you will probably remember this, but in the early spring of last year, just as we were preparing to bring preliminary 2021 rates to the board, we ended up having to cancel our March board meeting because of the pandemic and the ensuing stay-at-home order. By April, nearly all of our insurance carriers had signaled that they were going to need to pull back their proposed rates and recalculate them because of COVID. At the same time, all of our carriers assumed their rates were going up, but none of them had a sense of how much. The only analysis that existed had been produced by Covered California, who pegged the increase to be in the range between 2 and 40%. We pushed to delay our rates process as long as possible so we could learn more about the trajectory of COVID and to use that information to negotiate better rates. That ended up being critical because in the time between our first pre-COVID rates and the date in July when we formally adopted the final rates, we learned of a second important phenomenon, that counterbalancing the cost of treating new COVID cases was a dramatic decrease in the overall use of health services. Recall that in the spring, hospitals were canceling non-emergent procedures to make room for a possible influx of COVID patients, and Californians weren't seeing their doctors because they didn't feel safe visiting their doctor's office. The delays in bringing premiums to the board was also beneficial because it allowed us to bank considerable premium savings in 2020 and use them to buy down 2021 rates. Healthcare utilization has seesawed up and down for almost all of 2020. In the spring, utilization other than telehealth was de minimis. By midsummer, it hit pre-pandemic levels. And over the last few months, non-COVID healthcare use has started to really slow again. Unfortunately, the high numbers of hospitalized patients that we were able to avoid in the spring has become a terrifying reality. As you know, in many parts of the state, hospitals are literally full with COVID patients. So until we have the pandemic under control, we're likely to see fairly dramatic swings in spending. The spending associated with treating COVID patients is going to rise and fall with corresponding waves of pandemic. And we may also see the utilization of other medical services fall and rise inversely. Unfortunately, we also anticipate continued spending disruptions even after the pandemic is contained. One reason is that we expect most of the care that is deferred during these COVID surges will eventually be provided. I'm sure there's going to be someone out there who deferred a knee replacement surgery in 2020 or 2021, who for whatever reason decides against getting it later, but most patients are eventually going to come back. Another more troubling concern is that a lot of the care that has been deferred has been preventative, and some of it will come back as more acute, resulting in more serious care needs and new spending. We are very concerned about the long-term health consequences of care deferral that is being caused by the pandemic, and we know it is almost certainly going to increase overall spending in the long run. Lastly, we fully anticipate that there will be new costs associated with the treatment of some of the long-term effects of COVID, but because the pandemic has been with us for less than a year, we don't yet have a sense of their duration or prevalence. Sadly, I could go on, but as I mentioned, Dr. Logan is going to provide more detail in her COVID update, so I'm going to leave it at that. The next slide, please, slide 5. Let's turn now to the rest of the discussion of affordability. I'm going to turn things over to Marta in just a second, but before I do that, I'll note that when you talk about the affordability of healthcare, the question that often comes up is affordable for who? Are we talking about making it less expensive for the consumers of healthcare, or are we trying to bring more value for employers? In the past, making healthcare affordable sometimes meant pitting employers against consumers. Strategies for making it affordable For employers, meant reducing benefits or increasing cost sharing and making it more affordable. For consumers, meant passing more costs back to employers. But as we've discussed in the past, the growth of healthcare spending that has made healthcare so unaffordable for everyone isn't being caused by increases in the utilization of healthcare. It's being caused because healthcare prices continue to rise. And because of that, we believe the better goal is the one members and employers share, which is bringing down the prices we pay for healthcare. The prices we pay for healthcare goods and services are almost entirely disconnected from their quality. Healthcare really does bust the myth that you get what you pay for. In some parts of the state, CalPERS pays well over 50% more than it does for the same services in other parts of the state. With those increased costs, there is no increase in the quality of healthcare services, and in some instances, it's even lower. Our team sees increasing competition as one of the real keys to lowering prices. This is true for hospitals, for large health systems, and even for pharmaceutical costs. It's also a goal that we can all share since it lifts all of our boats. So I'm going to stop there and turn it over to Marta.
Thanks, Don. Marta Green, CalPERS team member. If you will recall from several conversations we've had over the past year, the number one factor influencing healthcare affordability, or the premiums we and our employers pay for health coverage, is healthcare prices, not utilization of healthcare services, as Don just mentioned. And in California, there is tremendous price variation. And as Don mentioned, the single most important factor related to the variation in healthcare prices is competition, or lack thereof. In consolidated healthcare markets where there isn't competition among providers, such as doctors and hospitals, to keep prices down, healthcare prices can be 30 to 70% above the statewide average. In general, in Southern California, there is a great deal of competition and lower prices. In the North, there tends to be less competition and higher prices. Similarly, in general, rural areas tend to have less competition and higher prices. This is one of the reasons why we embarked on a study with notable Harvard economists Limor Daphne and Robin Lee to determine the right quantity and mix of plans in each of our specific geographies to maximize competition and maximize affordability of our health plans. For the study, we're creating a model that simulates the effect of changing the set of plans offered to CalPERS members on enrollment, premiums, and the value provided to our membership. This model is built with a lot of historical information from our claims data warehouse and premium data, and will simulate the effect of offering specific permutations of plans in specific regions on enrollment, enrollment shares, premiums, and member utility to help inform our recommendations to the board for new plans and continued offerings of existing plans. We're excited to share the preliminary results of the study at the March board meeting and use those results to confirm the decisions regarding some of the new planned expansions the board approved last November. It is truly the first time CalPERS has used such a data-driven approach to inform our health portfolio decisions. This competition model, along with other existing tools, such as our annual member satisfaction survey and clinical performance measures, and those under development, like a new health plan efficiency rating, will be combined together as a comprehensive toolkit to rate our plans on performance, to inform future decisions regarding changes to our portfolio, all aimed to maximize affordability and our health plan performance. Next slide, please. Next, I want to talk about our pharmaceutical strategy. Another key and growing element of healthcare affordability is pharmaceutical pricing. Over time, pharmaceutical spending, which used to make up less than 10% of the healthcare dollar, is increasing as a percentage of total healthcare spending as more high-cost drugs enter the market. On an annual basis, CalPERS spends nearly $2 billion on prescription drugs for our members, and this has grown over time. Drug prices continue to increase due to lack of price control in the United States, limited competition, and ultra-high-cost blockbuster drugs coming to market. We continue to work on health benefit strategies and engagement to mitigate the rising cost of prescription drugs for our members without sacrificing the quality of the CalPERS health benefit. As you may recall, last September, the board approved the amendment of our existing PBM contract with OptumRx from its original trend and rebate guarantee style contract to a new acquisition price contract, along with an extension of 1 year to the existing contract term, with an option for a second year at CalPERS discretion. This new contract moves us away from the perverse incentives of relying on spread and rebates on expensive brand name drugs to achieve pharmaceutical savings, and instead improves transparency in drug pricing by structuring the contract based on the actual pharmaceutical pricing with built-in savings guarantees over the previous contract terms. This neutral chassis will allow for a variety of different innovative strategies to control drug spending, including formulary management. Another area that has potential to mitigate rising prescription costs is the promotion of a biosimilar prescribing. A biosimilar is a biological product that is very similar to a reference biologic and for which there is no clinically meaningful difference in terms of safety, purity, and potency. Biosimilar drugs are more affordable than their much more costly biologic counterparts, but are underprescribed due to targeted tactics employed by biologic manufacturers to delay market entry and deter prescribing of biosimilars. On January 1st of this year, we launched our Biosimilars First program with our PPO. This initiative makes the default prescription for certain inflammatory conditions a generic biologic instead of a name brand biologic drug. We'll be using the Biosimilars First initiative as a test case and an opportunity to learn more about the promotion of biosimilars. This will be implemented for new prescriptions and will have a medical necessity appeals process for individuals who have a clinical need for a brand name biologic drug. Based on our experience with this initiative, we are hoping to expand the program in the future. Over the next year, we'll be working to develop a strategy for management of high-cost specialty drugs, which make up about half of our annual drug spend. And we are continuing to remain updated on CalRx, California's generic drug label. The governor recently signed legislation that allows the California Health and Human Services Agency to partner with drug manufacturers to make or distribute generic drugs. CalRx seeks to bypass the complex process of negotiation, rebates, and purchasing from private manufacturers. We will continue to keep you posted on developments of this important initiative. Next slide, please. Over the past year, we have made significant and dramatic changes to the rate development process to improve transparency in the factors that contribute to the rate and enhance our negotiating position. First, we realigned and moved earlier any new plan proposals, benefit designs, or service area changes to the quarter before initial rate filings. This ensures a level playing field so that all carriers, the board, and stakeholders are aware of all potential changes before rates are developed. This led to a variety of plan proposals discussed last November that I'll cover on a later slide. Arguably the most important to rate setting, CalPERS staff developed our own projected baseline rate for each rating year using capitation payments and fee-for-service claims in our data warehouse with assumptions for unpaid claims liability. To this baseline experience, we applied actuarial assumptions to project the costs including utilization trend, unit cost trend, changes in population risk, and geographic mix. This baseline rate is a starting point for all plan negotiations, and it gives CalPERS a benchmark against which to compare all plan rate proposals. This puts CalPERS in a much stronger negotiating position. The rate process becomes more of a reconciliation between CalPERS numbers and the plans. Lastly, we are moving the rates calendar a month later in the year, again this year. Like last year, preliminary rates will be released in June, with final rates being released in July. Having CalPERS first out of the gate with rates before Covered California and all other major commercial purchasers puts us at a negotiating disadvantage. Carriers are incented to set rates higher for CalPERS to demonstrate cost savings for later purchasers. This new timeline for 2022 rates removes this incentive and further strengthens our negotiating power. Next slide, please. One of the most significant challenges that CalPERS faces is lack of lower cost integrated basic health plan options in rural counties, counties that have consolidated healthcare markets, and generally sometimes throughout the portfolio. This leads to two significant problems. The first is lack of choice in those counties without the lower cost integrated choice options. And the second is the overall impact to rates within the portfolio. Through working with our carriers over this past year on CalPERS priorities and gaining approval of the comprehensive risk mitigation approach I'll discuss in a moment, we were able to secure the expansion of a number of integrated or lower cost options into a variety of rural or consolidated healthcare markets, or markets that could benefit from additional competition. These new options include the expansion of the Access Plus EPO into 2 rural northern counties, the reintroduction of Access Plus into the Bay Area that had exited in 2019, the potential expansion of Trio into Monterey, Orange, Santa Cruz, and Stanislaus counties, the potential introduction of a new United Healthcare Harmony product in 5 Southern California counties, and the expansion of Western Healthcare Advantage into a rural northern county. A number of these potential expansions are dependent on the outcome of the competition study I described and will be confirmed with the board in March. Additionally, we are continuing to work with our carriers to expand Medicare Advantage offerings so that members can experience continuity in their healthcare coverage as they age into Medicare, and new optional benefits authorized under the Chronic Care Act designed to keep members healthy and out of the hospital. Lastly, we are working to redesign the PPO portfolio to simplify the basic plan choice and align with the current 2 Medicare supplement plan design. Next slide, please. As you know, last November, the board approved a new risk mitigation approach to the basic portfolio called portfolio rating. This is because the basic portfolio was experiencing very volatile premiums and member migration patterns. This was due to adverse selection, or when healthy members and sick members concentrate in certain plans and cause that plan's pricings not to be tied to the plan's value. Because of adverse selection, plans had been forced to reduce their healthcare costs to remain competitive by introducing network alternatives that only attract healthy risk, exiting high-cost areas, or removing providers that do an exceptional job of treating high-cost conditions. In short, plans have not been competing on cost and quality, but instead on how they can attract members that use little or no healthcare. The instability in the basic portfolio was preventing the type of innovation, increased competition, healthcare integration, and cost containment necessary to improve care quality and affordability for our members and employers. With the new portfolio rating approach in place, instead of focusing on mitigating adverse selection, we can appropriately focus our time and energy on innovative cost-saving and quality improvement programs, bringing the right kind of plan competition in each geography of our state, and encouraging the right provider partnerships to deliver care in low-cost, high-quality settings. All of the novel affordability approaches we've discussed today are predicated on this stable basic portfolio. Already, we have proposed new plan offerings in rural and consolidated markets for the 2022 plan year, with more on the horizon. As we discussed in November, the new portfolio rating approach will be phased in over 2 years to minimize member disruption. With that, before we move on to the next session, I'll pause for questions. David?
Thanks, Marta. So not seeing it right now, but why don't we give a moment here? So folks, if you have a question on anything that we've discussed so far, go ahead and either type it in there under the QA button, or you can go ahead and raise your hand and we'll unmute you and you can speak to the larger group. I'm also checking my email if something comes in. Okay, so we've got one. So I'll go ahead and read this one out. So Marta, you mentioned aligning the PPO basic plans with Medicare plans. Can you elaborate on this from Joanne Hollander?
Yep. So actually, in the Medicare program, in the Medicare supplement program, there's technically only 2 Medicare supplement plans. So both PERS Care and PERS Choice on the Medicare supplement plan are identical plans. And PERS Select is a different plan. So what we're going to be doing on the basic side with the transition to PERS Platinum and PERS Gold is transitioning to a 2-plan design. So the basic will then mirror the Medicare supplement as a 2-plan design.
Good, thank you. Okay, so I'm not seeing any more raised hands. I want to give just a couple of seconds as folks figure out the navigation here. Either type in or raise your hand. All right, seeing none at this time, we'll go ahead and move on. Don't worry, we have ample time to ask questions at the end as well, folks. So let me go ahead now and pitch the mic over to Dr. Logan, and we'll get an update on healthcare quality and access. Go ahead, Dr. Logan.
I think I was very briefly introducing her.
Oh, my apologies, Don.
That's quite all right. So I'm going to turn things over to Dr. Logan. I'll do essentially what David just did. She's going to be giving an update on COVID. She's also going to be leading the discussion of our goals of improving healthcare access and quality. Dr. Logan, why don't you take it away?
I do see her on the line. She is there. Dr. Logan, we cannot hear you. Let's see. One moment. I don't have an email from her either, Don. So I don't know.
She's aware.
Okay, she's calling in now. So just a few moments of patience, folks. We'll get her connected. Right.
Either play a little music on my phone or
I'll hum a tune here.
If there are any other questions in the meantime.
So, Dr. Logan, in that chat box there, can you just type in your phone number that you called in from so we can match it up?
Can you hear me now?
Yes,
Yeah.
There we go. Yes.
Is that better? Can you hear me? Okay, I'm sorry. I was trying to alleviate any dog barking, but I guess it didn't work out too well. Okay, so thank you for your patience. And then if we can advance the slide. Thank you. At the onset of the pandemic, uncertainty prevailed, and there really was a lot of things, so many things we didn't know. We didn't know if masks protected others or ourselves, now we do, how the virus was transmitted and how contagious it was. To slow transmission and decrease the burden on our healthcare system, urgent visits were prioritized and states delayed elective care. A lasting consequence of the pandemic has been the underutilization of important medical services for patients with non-COVID-19 related health needs. In fact, nationwide, hospitalizations for general medical conditions like heart attacks and bladder infections are down by more than 20% during the pandemic. Now that we're 11 months into this and we've learned a ton about the characteristics of the virus, and while there's still a whole lot more to learn, we now know that we have to balance the need to provide necessary services while minimizing risk to patients and healthcare personnel. Our plans are communicating to members that preventive care, ongoing care, and procedures must go on and can be done safely, and we continue to make this a priority. We are anticipating that there may be long-term health effects, not just of people who have contracted COVID, the so-called long haulers, but also the long-term consequences of more than a year of millions of people in our state avoiding preventive care like cancer screenings and the management of chronic conditions. Another consequence of the avoidance of care manifested itself in our 2021 premiums. And as Don mentioned, because of the delayed and deferred care and relatively low COVID rates early in the pandemic, there was only about a 0.5% impact on our 2021 premiums. No doubt, COVID-19 has had an immeasurable and lasting impact on each and every one of our lives. It has had an especially large impact on our emotions, the uncertainty, the loss or sickness of loved ones, the isolation from coworkers and friends and family, and concerns of essential workers. They might actually get sick on the job. So it certainly impacted us as individuals, and it's also disrupted the status quo of the healthcare system. One major and enduring way is the unprecedented uptake of telehealth. Prior to the pandemic, telehealth was an evidence-based and underused modality that just didn't really have any traction for several reasons, but in part because of technology challenges and payment barriers. In about the span of a week in our state, providers and patients alike had adopted telehealth almost universally. It was really quite amazing to witness and be a part of. I do want to emphasize, however, that while telehealth has been a crucial way to provide care during the pandemic, it's not the only option for care and should be used really to complement and not replace care for our members. We do anticipate that because many members have embraced telehealth, that it's here to stay, at least in some way, for many years to come. Another way that COVID has impacted the healthcare system is in the way it's peeled away and laid bare the profound inequities in our society that manifest in health outcomes. While health inequities were certainly there pre-pandemic, COVID has made us all aware now that we need to act on these inequities, and I'll talk more about that in a moment. Next slide, please. COVID vaccines are here. And it's really remarkable that less than a year into this pandemic, we actually have 2 vaccines that have gone through clinical trials and are FDA authorized. Authorized vaccines have been shown to be safe and effective in clinical trials and undergo a rigorous review by the FDA and other independent scientific panels, including an additional review by a California Scientific Safety Review Work Group. So it's really one of the great triumphs of modern science and maybe Nobel Prize winning, we'll see. The 2 vaccines that demonstrated 94 to 95% protection against COVID in clinical trials, one developed by Moderna, the other by a collaboration between Pfizer and the German company BioNTech, progressed so quickly to clinical trials precisely because they are the fastest to make and manufacture. They rely on a vaccine technology called mRNA technology. An mRNA vaccine doesn't actually contain the virus itself, unlike many other vaccines. Think of it as an email sent to your immune system that shows what the virus looks like, instructions to kill it, and then, like a Snapchat message, it disappears. It's just unbelievable technology. mRNA vaccines are fast to make, but extremely fragile. These vaccines have to be frozen, and in Pfizer and BioNTech's case, at an ultra-cold -94 degrees Fahrenheit, colder than most freezers, which limits how and where they can be shipped. The way these vaccines are formulated without added preservatives and packaged in vials that hold doses for multiple people also make them easier to develop and manufacture quickly, but much harder to administer on the ground. The 2 vaccines both require 2 doses, and it will be important to take the second dose of the original vaccine you received. There are different doses, different amounts in each vaccine and different compounds. And it's the second dose that helps with the long-term immunity, so be sure you get that second dose. Pfizer's vaccine is FDA authorized for people 16 and above, while Moderna's vaccine is approved in people 18 and above. Moderna is working on clinical trials in children, though because of inherent challenges with vaccine trials in children, we don't expect to have results of its trial before 2022. And yes, for a while, we will continue to wear masks and socially distance even after getting vaccinated. I like to think of it as a belt and suspenders approach. It's especially important right now as we ramp up vaccinations over the next few months. A few more vaccines are in the pipeline, and the Johnson & Johnson vaccine is the next one in line, I think. It's expected to be a one-dose vaccine, though it's being tested as a 2-dose vaccine as well, and is not mRNA technology. Johnson & Johnson expects to release critical results from its COVID-19 vaccine trial in February. A 1-dose vaccine could greatly simplify logistics for local health departments and clinics struggling to get shots in arms. What's more, its vaccine can stay stable in a refrigerator for months, whereas the others, as I mentioned, have to be frozen. Regardless of which vaccine you get, the vaccine and its administration will be available to you at no cost, regardless of where you get the vaccine. And I do want to spend some time on vaccine distribution and administration, because I know there's understandably intense interest in this and it's constantly changing. Just remember that this is a really large undertaking and really the largest vaccination program in history. It's a mass production of a vaccine, mass distribution, and then a mass administration program, and right now with a fragile vaccine. And there are a lot of unknowns, including uptake of vaccine. So how many people are actually going to get it when offered, which has been a big factor in getting the vaccine into people's arms in a timely way and has led to some stories you may have heard about extra doses lying around after vaccination events. Right now, our state, like every other state, is beholden to the federal government in terms of how much vaccine supply they get. Our state gets told on Tuesday how much vaccine, every Tuesday, how much vaccine they'll get. And the amount of vaccine depends in part on the state's total population, not on their over 65 population right now. So it makes it really hard to plan week to week. And then our local county health and large health departments and large health systems like Kaiser and Sutter and the UCs are beholden to the state health department also in terms of how much vaccine they get. Of course, now that we have a new administration, we should expect to see changes in the vaccine rollout. And President Biden has pledged to administer 100 million doses in his first 100 days. As of today, 3,226,000 vaccine doses have been distributed to California. Of those, 1,454,000 vaccine doses have been administered. So this is about 45% of the doses that have been administered. Because of the currently limited supply, the state has implemented a tiered approach to vaccine distribution. The goal is to get everyone who wants to get vaccinated by the summer of this year. The first doses have been administered to those at highest risk of becoming infected and spreading COVID-19. And this first 1A priority group has included healthcare workers and skilled nursing facility residents. This group consists of more than 3 million Californians. And many counties are still working to vaccinate all of Group 1A. You may have heard about the different priority groups beyond 1A. 1B includes 2 tiers. 1B Tier 1 is individuals 65 and older, and those at risk of exposure at work in the education, emergency services, and food and ag industries. And Tier 1, Group 1B Tier 2 includes those at risk of exposure at work in transportation and logistics, industrial, commercial, residential, and sheltering facilities and services, and those living in congregate settings with outbreak risk, like incarcerated individuals and the homeless. Phase 1C includes individuals 50 to 64 years of age and people 16 to 49 who have an underlying health condition or disability, which increases their risk of severe COVID-19. It also includes those at risk of exposure at work, including waste, communications, and IT, and government operations. And while those priority groups remain in effect, late last week, the Department of Public Health announced that because of our current surge, California will now prioritize vaccinating healthcare personnel and all persons 65 and older. That comes with a big however, though. Because supply is incredibly limited, the state is recommending prioritizing and targeting certain groups first, including people 75 and older, those with high occupational risk exposure, and people living in vulnerable communities. And because there have been many instances when vaccine doses are at risk of being wasted, health departments and providers may offer doses promptly to people in lower priority groups when there could be any threat of wasting doses, like when doses are about to expire or when doses that have been thawed would otherwise go to waste. In terms of availability, currently vaccinations being given at doctors' offices, clinics, and pharmacies, and that's happening, but the number of doses in these settings is really limited. Mass vaccination sites are being planned and established to increase distribution in several counties, including Cal Expo and Dodger Stadium. Dodger Stadium is now open by appointment to healthcare workers, and it sounds like to people over 65 in a few days. Disneyland is another mass vaccination site, which is now open to those 65 and older. The exact timeline for moving through the phases depends on a lot of factors, including your location in the state, the availability of supply, distribution barriers, and additional vaccine approval. Health plans and providers will be moving through at different paces, but one thing now is universal: the supply is severely limited. So right now, the best estimate for 1B Tier 2 to be eligible to be vaccinated is later this winter, and 1C sometime in the spring. In this current vaccination plan, California state employees would fall under government operations in phase 1C. You can imagine how inundated health systems and provider offices have been, receiving thousands of calls and visits to their websites. Many health systems have implemented a "don't call us, we'll call you, and please be patient" approach to try to mitigate the call volume. And you may have gotten a message like this from your plan or your provider. Late last week, the state announced that they will unveil a vaccine eligibility notification system, though we don't yet know the details of this system. Right now, it's being piloted with healthcare workers. Of course, these guidelines, availability, and information on the notification system continue to evolve, and we're following these developments very closely and communicating with our health plans frequently on this. We put information on our CalPERS website about the distribution process to help keep our members apprised. And I think this was put up late last week. However, we look to the primary sources for information: the Department of Public Health, the Governor's Office, and we will be following their guidance and lead on this. Your health plans are also updating their websites frequently and are communicating with members about their vaccine availability. Please check their sites and check with your provider on their plans for vaccinating patients. So if we can move on to the next slide. Okay. Yesterday, we gave an update to the CalPERS board about our experience related to COVID-19 and behavioral health services, our continued challenges, and what we've done over this past year to improve behavioral health access and quality on behalf of our members. And in case you missed it, I'll give you a brief synopsis. We've been tracking behavioral health utilization over the course of the pandemic. And what we've been seeing is that a dramatic increase in behavioral health utilization since March 2020, and a concomitant increase in telehealth services. And it's not surprising given the national rise in depression and anxiety during the pandemic and the extreme stress we've all been under. With this increase in behavioral health utilization, we always keep our eye on the volume of behavioral health grievances and appeals to make sure that our members are not encountering challenges in accessing care or in the quality of their care. Thankfully, we have not seen an increase in the past year in the volume of grievances and appeals related to behavioral health. We also updated the board on our work in quality and quality improvement in behavioral health and access, such as changes we've made to the health plan member survey to get a better idea of our members' behavioral health treatment needs, and work we're doing with UC Davis on focus groups to better understand any barriers our members may be facing. And then last, our health plans are doing some really innovative work and have started evidence-based programs that really focus in on improving outcomes, promoting resilience, and overcoming barriers to access. Another interesting innovation that all our plans have started working on is the judicious, sorry, that's a hard word to say sometimes, use and integration of technology such as apps and online resources into existing care pathways. It's really fascinating, and I was a bit of a skeptic at first about these, but there's a lot of evidence that shows that these tech solutions can increase access, decrease wait times, really sometimes from days and weeks to hours, and help improve communication between behavioral health providers and primary care physicians. So more to come on this and our other work in behavioral health. It's really a work in progress, but we're in this for the long haul on behalf of our members, and we're looking forward to the work ahead. So next slide, please. Thank you. As you know, we're committed to providing high quality care at the right time for our members. Because this is so central to what we do, we have a multi-pronged approach to ensure high quality. One area is in alignment with our other healthcare purchasers in the state, such as Covered California and Medi-Cal, and this is a really important one for us. And we talked a lot about it to the board yesterday. By unifying our collective focus and working together on the issues that matter, we will be able to amplify our message and exert our collective influence among health plans and providers throughout the state. And this alignment is something we've been consistently investing our time in at all levels in the health team. And we've been participating in alignment work focusing on our healthcare quality measures, behavioral health, and clinical quality issues, including our COVID-19 efforts. You'll be seeing more and more of this alignment in our contracting and quality metric alignment in the next year. And in terms of clinical quality measures, we hold our plans accountable to clinical quality using healthcare quality measures that are nationally recognized and have an established benchmark, so we can measure ourselves against a national standard. We choose these measures and review them annually using specified criteria to ensure we're measuring and improving qualities in areas that matter. Another area of focus is health data quality, and we're focusing on making sure our data is complete, consistent, and timely so that we can make better and more informed decisions about clinical issues, appropriate utilization of services, and rate setting. And finally, health equity, which I'll discuss more on the following slide. So if you can advance the slide, one back, yeah, thank you. I mentioned earlier the connection between the pandemic and our health equity efforts. The pandemic and the racial injustice events of 2020 have exposed long-standing inequities that have consistently undermined the physical, social, economic, and emotional health of minority populations here in California and nationwide. While these events have been horrific in so many ways, we have a responsibility to understand and work to eliminate these inequities. Here in California and throughout the United States, racial and ethnic minorities and other disadvantaged groups are bearing a disproportionate burden of illness and death due to COVID. This is especially concerning in our state that has embraced the Affordable Care Act and Medicaid expansion in an attempt to provide coverage and access to the vast majority of its residents, where efforts were made early on to expand no-cost COVID testing to all state residents. In our state, Latinos make up about 40% of the state's population, but account for 61% of coronavirus cases and nearly half of the deaths. The Black community is 6% of the population, but accounts for more than 10% of deaths. Compare that to the white population, which is about 37% of the population, but 17% of cases and just about 30% of deaths. And challenges remain in our state to provide equitable care and health outcomes for non-COVID health issues as well. Black and American Indian or Alaska Native Californians continue to fare worse compared to white Californians across most measures of health status, including physical and mental health, birth risks, infant mortality rates, and HIV death rates. Native Americans have the highest rate of overdose deaths from opioids. The rate is 3 times higher than the California average. There is a close link between diabetes and low social or economic status. In California, ethnic minorities, the elderly, and individuals who are poor have significantly higher rates of diabetes. Also, while looking at data at higher levels like national or state level or by large populations can be really helpful, but certain disparities can be hidden. For example, life expectancy at birth in California is 80.8 years, which is about 2 years higher than the national average. But for Blacks, it's 75.1 years, and for Asians, it's much higher at 86.3 years. So sometimes you have to look at data in different ways to get the full picture of disparities. These inequities negatively impact the health and well-being of the populations that constitute the majority of Californians and that will be increasingly representing over half of the nation's workforce and its taxpayers. So really, the elimination of health disparities and the creation of health security for all are vital to creating the kind of future we all want for our children and for our grandchildren. At CalPERS, we believe that these disparities are unacceptable. Addressing health equity and disparities in healthcare is integral to the CalPERS mission and has been incorporated into our strategic plan. We've been looking at what we can do to address disparities, but first we needed to better understand the diversity of our own membership through our data. To help get the data we need, we've created a health demographic profile in CalPERS that only members can view. And Rob Jarzambek just spoke about this at the last session about the launching of this profile. Starting this past weekend, when subscribers log into their MSS account, they can choose to share information like race, ethnicity, preferred language, sexual orientation, and gender identity. Completing the profile is optional, and it will only be available to the member who completes it. We are currently developing a framework for using this CalPERS data to identify any inequities in health outcomes among our members, such as diabetes, member satisfaction, or in the frequency and resolution of grievances. I really encourage you to complete your own profile. It only takes a few minutes, and it will give us the data necessary to understand better who our members are, and then in turn use that information to make real change in reducing and eliminating health inequities. And it will help us improve our ways of engaging with and communicating with our members. We're really proud of this work, realizing that this commitment to achieving health equity is a long-term one, and we're looking forward to updating you on our progress in the coming months. With that, I know that was a lot of information. I'll pause and stop for questions.
Thanks, Dr. Logan. That was a lot of information. Thank you for that. So let's go ahead and go to the questions. Again, if you have questions or comment, go ahead and raise your virtual hand or go ahead and type them into the Q&A and we'll get to you. So I see that we do have a couple popping up. So let's go ahead and start with Tim Behrens. Go ahead, Tim.
Thank you, David. Thank you, Dr. Logan. That was very thorough and informative information. I'll give you an example. In my little county in Central California, I received an alert this morning from the health department that we've already maxed out the first round of shots, so I have to wait till next week and see if I'm eligible as we get more vaccine in. I'm wondering whether you had any updates on the new COVID that's popped up in the UK, that they've shut down the whole UK now because of a new outbreak. Hello?
We're working on it, Tim. Hold on. You're good, Dr. Logan. Go. You should be unmuted now. Dr. Logan, I believe we can hear you if you give it a shot here. Oh, can you hear me now, Dr. Logan? Okay, so I'm gonna, she can't hear you, Tim. I don't know.
I think we can probably, while she's trying to figure out, and she'll be able to add a lot more detail, we can at least partially answer the question, which is that that particular variant has been was identified pretty early on in California. And there is an expectation that it will eventually become the predominant strain. Just yesterday, we also identified a new, so far, California distinct variant. None of them so far, thankfully, have shown as more lethal, but certainly the British variant has shown as more transmittable.
Thank you, Dr. Moles.
Hello?
Yeah, there we go.
Now we can hear, Julia, can you hear us? Yeah, we can hear her. She can't hear us. Dawn, the other thing, I think that we have no evidence to believe that any of these variants are problematic with the current vaccines. I think right now we believe that the vaccine, the currently distributed vaccines will work with the new variants. All evidence points to that direction. Dr. Logan would do a much clearer job of answering that question, the two of us, but we're trying.
Can you hear me now?
Yes.
Hey,
I really apologize. I don't know what happened. So I hope everyone heard what I was saying.
We heard you.
We answered the question. You would have done a much better job if you want to double back. We said we mentioned that the UK variant was identified early on in California, that it's expected at some point in the spring to become the primary variant in California. That just yesterday, California identified a so far unique variant. None of them have shown to be more lethal, but at least the UK variant's more transmittable. And Marta made the point that so far the evidence suggests that the vaccine will be effective for all of them.
That sounds great. Yeah, and variants and mutations are part of being a virus. And so viruses mutate and change all the time, and they get smarter with time. And so this is to be expected. And it's just really important to remain vigilant, wear your mask and socially distance, because we don't know, we're still learning about the variants, and we're still learning if they are more transmissible, especially like the California one. And so, but like you said, so far the vaccines seem to be strong against them. So that's the good news.
thank you.
Thank you, Tim. Okay, next, we do have another question. Go ahead, Larry Woodson.
Good afternoon, Larry Woodson, CSR. Thank you, Dr. Logan, for a very thorough presentation on COVID. And I do have a follow-up question. You did mention the importance of getting the second dose with the Pfizer and Moderna. But there's an issue I didn't hear you mention that's of concern to me and probably many others. The CDC, along with the state of California, announced their strategy to use the second doses immediately to get them out to a wider population and use them as first doses. Presumably to go down in the tiers. And I know that Dr. Fauci and other pandemic experts have expressed concern about that, given that the research on them was based on a very specific 3 to 4 week follow-up with the second dose. And so I think there are concerns about the availability. I know the federal stockpiles are gone. And so I have concerns about the availability of those drugs if we are indeed following that strategy. And do you know the latest status on that?
I agree. I agree with Dr. Fauci and all of the experts that getting that second dose is certainly important, and you do not want to delay. You shouldn't delay. The second dose is really where the long-term immunity comes in. So it's very important, especially as we think about the variants. From what I know and what I've been reading, I don't think that it's going to be an issue, because while the federal government was holding back the second doses, they aren't now, but that supply will be sufficient for the second doses.
Well, so are you saying that California and and the other states that have been encouraged by the feds to do so are not going to be using the second doses as first doses?
I think they will be, but there will be more supply coming. So that the second, even though we're technically using the second doses, more supply will come to fill that gap.
Okay, well, I mean, that's what we're all
That's our
hoping
hope,
for, but
sure.
they have to come pretty quickly, like within 3 weeks, if they're going to use the second doses as first. Okay, thank you.
Mhm.
Thank you. Any further questions? I'm not seeing any in the Q&A at this time. If you'd like to ask a question or make a comment, please go ahead and raise your e-hand. All right, seeing none, we'll go ahead and move on. Thank you, Dr. Logan. Really appreciate that. Next, I'd like to turn the focus of the conversation to federal and state policy and legislation. We've had something of a change in these areas recently, so I think there's ample opportunity to discuss what the future could look like, what we do know, what we don't know. So I'd like to invite our Chief of Legislative Affairs, Danny Brown, into the conversation, and also invite Marta Green to provide her insight on the topic as well. Go ahead, Danny.
Thanks, David, and good afternoon, everybody. As David said, I'm Danny Brown, the Chief of the Legislative Affairs Division. And Marta and I would like to take the last moments of this session to discuss CalPERS federal and state health policy and legislative priorities for the year. But it's probably important to start by discussing the political landscape and setting expectations. I'm going to start at the federal level, since that is where we likely will see the most activity on issues that could impact our health plans. And after 4 years of split government, President Biden administration is starting today with control of both the House and the Senate. And there's likely going to be a lot of pent-up demand to move on a number of Democratic priorities. But we are looking at a House majority that is the smallest in, I think I read, 100 years, and a 50-50 split in the Senate. So what does a 50-50 split in the Senate mean? On one hand, it does give control of the Senate to the Democrats because Vice President Kamala Harris gets to break any ties, and ultimately the Democrats will chair the committees. However, the committee membership ratio could still be 50-50, as was the case the last time we were in this situation in 2001. As a result, committees were only able to move bipartisan legislation. And under this scenario, the majority leader could still add legislation to the Senate calendar in order for it to be considered outside of the committee process. Though last time that also required both the Republican leader and the Democratic leader to agree on skipping the committee process and going right to the Senate floor. Senator Schumer is still in negotiations with Senator McConnell on what the rules will be. So it's unclear still at this point what the approach will be, but obviously there'll be some pressure on Senator Schumer to retain some control outside the committee process. So I guess the point I'm trying to make here is with the small margins in both the House and Senate, and the need to have 60 votes on any piece of legislation that moves through the Senate under normal business, we are still looking at the fact that most legislation needs to be of a bipartisan nature to have any chance of success. There will be a few exceptions for President Biden's biggest priorities that could go through the budget reconciliation process, which only needs 50 votes. But Congress can only consider 3 reconciliation bills per year. And again, given the slim majorities, reconciliation packages are likely to be the product of careful negotiations to ensure party unity. So now, sorry if I started off with some doom and gloom on day one of President Biden's administration. So let me just spend a little bit of time about what may get done. I think the first priority for President Biden and Congress is to get control of the COVID-19 pandemic. This is illustrated in President Biden's $1.9 trillion economic package that includes $400 billion at fighting the pandemic and accelerating vaccine distribution. And we just learned this morning that President Biden will issue 3 executive orders today dealing with the pandemic. 2 other important areas that the Biden administration and Congress will focus on where we may see some incremental change is protecting and expanding and lowering prescription drug cost. With respect to the ACA, we should expect things as expanding insurance subsidies to more people, rolling back of the Trump administration's changes, and other long-needed cleanup. The debate on lowering drug prices will start from where it ended last year using Grassley and Wyden's bipartisan Senate bill and the House's Elijah E. Cummings Lowering Drug Costs Now Act as the starting points. If Congress focuses on the provisions of these two bills that are in common, we could see some incremental change. But if direct negotiations on drug prices is a must-have, then it could get stuck in the Senate again. Many of the priorities of the President and Congress line up with the priorities of CalPERS for this year. CalPERS strongly supports legislative and regulatory changes that improve affordability and quality of care for our members. Specific areas of focus during this legislative session at both the state and federal level could include strengthening the COVID-19 response to try to put an end to the pandemic and updating federal regulations around COVID-19 treatments, lowering prescription drug pricing, curbing anti-competitive practices around healthcare consolidations and generic drugs, improving behavioral health treatment, promoting healthcare system improvements such as those that aim to achieve better care for patients, smarter spending, and healthier communities, and health equity. That's the priorities at a very high level. As we get farther in the year, we can add a little bit more to those priorities, especially as Congress kind of gets settled in. But there is one last priority that I would like to spend a little bit more time on, and it is surprise billing. As many of you may know, the last stimulus bill that Congress passed at the end of 2020 included a ban on surprise billing that will go into effect on January 1st, 2022, and will apply to the roughly 400,000 members that participate in our self-funded plans. So at this time, I'd like to turn it over to Marta, who was involved in a lot of the conversations at the federal level on this issue, and she can discuss this piece of legislation in more detail in our next steps. So with that, Marta.
Thanks, Danny. I think, as you all know, surprise billing has been somewhat of a passion project of mine as I worked on the successful state legislation to ban the practice here in California and implemented the law in my previous role. Here at CalPERS, Danny and I spent a lot of time in DC, both in person and through the magic of Zoom, providing technical assistance and information regarding California's successful ban to congressional leaders, congressional members. I'm thrilled that ultimately the legislation was passed, though it didn't contain a key cost-saving provision that we had hoped for, a default payment rate to keep many billing disputes out of potentially expensive arbitration processes. However, there will be an opportunity to engage in rulemaking as the bill requires the Secretaries of Health and Human Services, Labor, and the Treasury to promulgate regulations related to the process payers misuse to determine the reimbursement amount, how providers complain if payers violate whatever the enumerated process is, and the final details of the arbitration process. We look forward to engaging in the rulemaking process to ensure that the law is implemented in a way that protects patients but doesn't unnecessarily increase costs. With that, I'll turn it back over to Danny for state updates.
Thanks, Marta. So I'll just close by touching on the state level activities, which at this point, it is unclear beyond addressing the COVID-19 pandemic what the state legislature will take up with respect to healthcare as we wait for more bills to be introduced. While we do expect the session to overall run much smoother, however, the pandemic has already had an impact by limiting the number of bills that members can move this year. There will be, though, a few areas that we will continue to engage on that are priorities of the governor's office. First, we have a couple of initiatives from the current year's budget that we will continue to be involved with, which are the Healthy California for All Commission and the CalRx program that was mentioned earlier. And then there is the Office of Healthcare Affordability, which was part of the governor's proposed 2021-22 budget that was released earlier this month. And let me again turn it over to Marta, who can speak about this new office in a little bit more detail.
Thanks, Danny. I'll just add that the new Office of Affordability builds on the price transparency work that the administration has built over the last few years, including the establishment of a healthcare payments database at the Office of Statewide Health Planning and Development. CalPERS has partnered closely with OSHPD on its development and will continue to support it through its launch. CalPERS is in a unique position to do so, as we have had our own version of an all-plan claims database since 2008. We also continue to provide technical assistance to the administration and to members of the legislature regarding the establishment of the Office of Affordability, and are keenly interested in the cost targets and transparency work that it will undertake. And with that, I'll pass it back to Danny to wrap up.
Thanks, Marta. That's actually concludes our presentation. So David, we are ready for any questions that the audience might have.
Thank you. I do see a question coming in. One moment. Now, I am having issues here. Okay, Larry Woodson, go ahead.
Okay, thank you. Larry Woodson, CSR. So Danny, thanks for the update. I have two questions. I guess one is kind of to Marta's talk about the surprise billing legislation. The one thing that it didn't cover was surprise ambulance charges, which has actually been a concern to some of our members who've been hit with those. And they're not, huge bills like some of the others, but $400 or $500. So I don't know if there will be any effort at follow-up legislation to address those. And then my second question has to do with the regulation, Danny, that we talked about earlier, the regulation that was passed at the end by the Trump administration, at the end of his administration, and you guys CalPERS sent a letter opposing it and expressing concerns about it regarding the removal of the safe harbor protection for rebates on prescription pharmaceuticals. And I just wondered, now that we have a new president, I understand he has the ability to overturn some of those regulations, last minute regulations, but in doing so, he would lock up the ability to promote new ones on the same topic for some lengthy period of time. So could I get you guys' take on both those issues?
Sure, I'll jump in on the ambulance one. I've not heard of any specific legislative proposals either at the state or federal level tackling the issue of surprise ground ambulance billing. It is a little bit more of a thorny issue because it involves local government, because oftentimes the transporting agency may be a local government entity that is affiliated with either fire, like an ambulance through a fire department. And so it's a little bit harder from a local budget issue. And so that is why it's been harder to tackle. So I haven't heard of anything, but if we do hear of anything, we will keep you posted.
Okay, thank you.
I do think there was a commission, and commissions without authority are about as powerful as they sound. But there was a commission, I think, that was created by the legislation to look at the ground ambulance problem. It did address the air ambulance problem, which was a catastrophic problem for people who got hit with a surprise bill, and these are $50,000 and $60,000 bills sometimes, right? Which can ruin a family, a lot of families. So.
And they can be even higher than that.
Yeah.
We at my old role, we had a 7-figure one once.
Yeah.
Okay. And then on the rule, Danny?
Sure. So on the rule, yes, I think there's going to be a desire to roll that back. Don't quote me on this, and I'll have to get back to you, but I believe that I was looking at some documents today that rolled out of the Biden administration of a list of things that he wanted his departments to look at. And I believe this was on their list, but I'll have to go back and verify it. But if not, I know that it'll be something that we, along with our other purchasing partners and associations we work with, would be looking to roll back. And I believe there's even a lawsuit that was filed recently this week on this rule. So I think there is going to be a lot of push to get this rolled back. And my recollection is it doesn't even go into effect until later. It hasn't even actually gone into effect. I think it goes into effect on the 29th.
Yeah.
Okay. All right. Thank you both.
But we will definitely be following it and report back to our stakeholders as we learn more.
That'd be great. Thanks.
Thank you. Any other questions at this time, be it on federal, state legislation, or any of the other healthcare topics that we've covered today? Now would be the time. Just want to open it up for you. Again, we do have the option for you to type in the question, just press that Q&A button, or you can raise your hand. Give a couple of moments here. I'm seeing none. Health team, you've just answered every question, apparently. You've covered every base. Well, we want to make sure that we do, of course, carve out time for public comment. So those of you watching on the board webcast, I think we do have one already, but those of you watching on the webcast, now would be the time to call in to the number there on the website, and we'll be able to bridge you over. But first, we can go ahead and offer the opportunity for public comment to anybody on the Zoom call who is actually participating directly in the forum. So if you'd like to provide public comment, you have up to 3 minutes, and just go ahead and raise your hand and I will unmute you. All right, seeing none at this time. Okay, let's go ahead and go to the public comments on the webcast. Renee, do we have somebody who'd like to provide comment?
Yes, David. We have one caller, Sarah Zimmerman from SCIU. Sarah, your line should be open.
Hi, can you hear me?
Yes.
Oh, excellent. Okay, thank you so much. Yeah, I have two quick questions. One was on the surprise billing. I represent SCIU Local 1000 members, and we have had a few members that had some questions about surprise bills they got from anesthesiology, and I'm trying to find out more information about which plan they're currently under, if they are currently covered and protected, or if they would only have been protected with the new legislation. But what should they do if they think that they have been unfairly charged?
So if they're enrolled in
a process set up?
So if they're enrolled in a CalPERS health plan, they can go ahead and contact either us, or if it is a fully insured plan, the Department of Managed Healthcare, and either one can help them. So figuring out which product it is helpful. It's important to understand that the federal legislation goes into effect on January 1st, 2022. So it is not currently in effect. And so if they're in the self-funded PPO, they do not currently have the protection, but they will in a year. So if we can find out whether or not they're in a state regulated product or not, then we can take it from there and get them some help.
Okay, so just call the general CalPERS number listed on the website. There's no special form or phone number or anything, just.
We can get you hooked up, or if Sarah, if you can figure out which product they're in and you can connect with me offline, we can get you hooked up with the right folks.
Okay, wonderful. Thank you. And then my other question was on the Office of Healthcare Affordability. I know that a number of labor unions are working directly with the governor's office on this office. And I'm just wondering how labor should best engage on this, because obviously on the CalPERS side, the regulations are going to apply possibly a little bit differently than they will in like the private market or through Covered California. And so I'm just trying to understand what is the kind of bird's eye view of how CalPERS sees the Office of Healthcare Affordability collaboration and where stakeholders fit in, since a lot of your stakeholders are going to be at both the CalPERS table and directly at the governor's table, if that makes sense.
I think that does make sense. Where we have been engaging at this point has really been technical assistance, because first they need to establish what the cost benchmarks are for the various services. And since the state does not yet have an operational all-payer claims database, yet CalPERS does, we have some experience with cost benchmarking in our data set. So that's kind of the level at which we've been engaging currently, not how in the future they're going to be setting those cost targets, which I think is really what you're driving towards and what your membership may be wanting to engage on, which is not where we have been engaging. We've been engaging on how you operationalize and how you go about learning what a cost benchmark is for a given service in a given geography.
Okay. And does CalPERS see whatever the office sets out as cost controls and limits, that they would directly impact the health plans and providers that are contracted through CalPERS, or would CalPERS not be subject to the office, or is it not clear yet? Does that make sense?
It certainly makes sense. I think the office, I think there is probably going to be additional legislation regarding the total purview of the office, and then how CalPERS engages with that legislation would go through our normal process where we would seek board approval to weigh in.
Okay, thank you so much.
Mm-hmm.
Thank you. Okay, so I think that transformed a little bit more just into questions, less so official public comment. So Renee, do we have any other members of the public wishing to offer public comment?
Currently, I have no more callers seeking public comment.
Okay, and I still don't see any questions within the Zoom. So I guess I would just pitch it back to the health team if you have anything you'd like to add. Otherwise, we can go ahead and close out the session, and we'll be moving forward towards our final session of the afternoon. Marta or Dawn, is there anything you'd like to add?
I will just say thanks to David for, as always, moderating a great session, and to Marta and Danny and Julia Logan for their terrific work in putting this together. So we look forward to talking with this group again next month, and the month after that, and the month after that. And if you have questions or thoughts in between those times, we're all available and happy to engage. So thanks much for your participation.
Wonderful. Thank you, Don. Okay, folks, so we're going to go ahead and wrap up this session. We're a little bit ahead of schedule, so let's go ahead and we'll push up our timetable slightly. Let's take a break until 2:15, and then we'll start the third and final session. That's 10 minutes in advance, but we don't want to take too long of a break here. So 2:15, we'll come back and we'll start our discussion of the asset liability management process. See you then. Thank you.